For those patients who are deemed transplant ineligible, for the standard risk patient, there are two major therapies that we recommend. Revlimid or lenalidomide and the weekly dexamethasone, or melphalan prednisone thalidomide, MPT. For the patient in the high-risk group, we recommend a combination of bortezomib, lenalidomide, and the weekly dexamethasone. The intermediate patients, either melphalan and prednisone with weekly bortezomib or the Cybor-D. Now, for those patients who are transplant eligible, I want to go into a little bit more detail about the options available. This is a study from the Eastern Cooperative Oncology Group, ECOG, that was chaired by my colleague Vincent Rajkumar, in which 445 newly diagnosed, previously untreated patients with symptomatic multiple myeloma were randomized to receive the lenalidomide 25 milligrams daily, days 1 to 21, which is the standard dose and schedule, plus dexamethasone 40 milligrams on days 1 to 4, 9 to 12, and 17 to 20, the so-called conventional dose and schedule of dexamethasone. Or to be given lenalidomide in the same dose and the same schedule, but dexamethasone given in a dose of 40 milligrams at weekly intervals. As you can see, at 1 year, the survival probability was 87% for the lenalidomide standard dose dex and 96% for those with the weekly dexamethasone. At 2 years, the survival was 75% with the previously standard dexamethasone dose and 87% for those with weekly dexamethasone. And for that reason, we recommend the weekly dexamethasone dosage. Another option is the so-called BIRD trial, which consists of lenalidomide, same dose, same schedule, plus dexamethasone 40 milligrams weekly, which is the same, but here chlorothromycin or Biaxin is added in a dosage of 500 milligrams twice daily. The complete response was almost 40%. The response, PR or better, in 90% of patients. There's no survival data that has been reported yet on this particular study, but it looks as good, if not better, than the lenalidomide dexamethasone alone. Another option for that newly diagnosed patient who is to undergo an autologous stem cell transplant is bortezomib. The standard dose 1.3 milligrams per meter square, twice weekly, days 1, 4, 7, 8, and 11. Plus dexamethasone 40 milligrams on the day of and the day after bortezomib. And again, one sees a response rate of 90% and an overall survival of 67% at 4 years. Now, one of the major questions today is whether patients with multiple myeloma and having an autologous stem cell transplant should be given a maintenance therapy with lenalidomide. And I'm going to show you two studies that were reported at ASH 3 months ago. The first is from the French myeloma group, in which 614 newly diagnosed patients with multiple myeloma were treated with lenalidomide and dexamethasone, and stem cells collected, transplant done, and these patients received 2 months of consolidation therapy with lenalidomide and dexamethasone, and then were randomized to receive continuing maintenance lenalidomide in a dose of 10 to 15 milligrams daily or placebo. And as you can see, the progression-free survival was superior in the lenalidomide maintenance patient, 42 months, compared with placebo of 24 months. However, the 5-year overall survival was identical in the two groups of patients. The other study that was reported also at ASH this last year was one from the CALGB cooperative group, in which 460 patients received an autologous stem cell transplant and then were randomized to receive lenalidomide 10 to 15 milligrams daily or placebo. And again, they measured the time to progression, which is similar to progression-free survival. And the numbers, 42 months until time to progression of their disease, compared to 22 months for those on placebo. There has been no survival data yet reported in this study. It's about a year or a little more behind the French study.